My name is Bill Hall, and on behalf of my co-authors, I'm very excited to be presenting the NRG Oncology Updated International Consensus Atlas on pelvic lymph node volumes for intact and postoperative prostate cancer. These are the authors' disclosures. In 2009, the RTOG, now NRG Oncology Group, published a widely utilized consensus atlas to assist with contouring pelvic nodal volumes for patients with prostate cancer. Considerable data has emerged since 2009, including molecular imaging data, further informing nodal recurrence patterns. We sought to generate an updated prostate nodal consensus atlas accounting for these data. This was the original publication from the RTOG in 2009, and these were the existing 2009 RTOG atlas contouring steps. We had three primary goals with this new atlas. The first was to account for novel patterns of recurrence data, including molecular, PET-based data, MRI, as well as clinical series that had described recurrences in relation to the existing RTOG contouring guideline. We also wanted to include a multidisciplinary group, not only radiation oncologists, but surgeons, radiologists, and nuclear medicine experts. And finally, we wanted to include novel circumstances, such as postoperative nodal contouring and clinically node-positive cases. A panel of international experts, including radiation oncologists, radiologists in nuclear medicine, and urologists, were assembled. Participants had extensive prostate publication records, along with research interests and publication records in patterns of recurrence specifically. An extensive literature review was performed, abstracting data on nodal recurrence patterns with over 100 manuscripts reviewed. Attention was given to publications since 2008, which was the time of the original RTOG atlas. There was then a presentation, extensive discussion, and correspondence examining this new data. Participants' contours were completed using MIM Cloud, and this was by 18 radiation oncology participants on 3 cases. We also had the surgeon's contour, however, those were not used for the primary contour analysis. The results were presented at the January 2020 NRG Oncology meeting in Houston for review and discussion. Community feedback was also obtained from the Michigan Radiation Oncology Quality Consortium. We used the Sorensen-Dice similarity coefficient and the Hausdorff distances for quantitative contour analysis metrics, and we also used something called count maps for more qualitative contour assessment. For those of you not familiar with count maps, this is a method by which each voxel value is determined by the superposition of observers that included that voxel in their nodal CTV. So, for example, if you have 18 observers, your maximum count would be 18. If all of the voxels were included in a contour, then they present as a solid single color. If some of the voxels were not included in a contour, they present as a different color based on the number of observers that included those voxels. So within a count map, you can have different isosurfaces with different colors generated. This enables a qualitative assessment of the contour variation, and I'll present some examples of this subsequently in the presentation. So we had a total of 18 radiation oncologists that completed full contour sets on 3 cases. Those included an intact node-negative case, an intact node-positive case, as well as a postoperative case, and this was 54 completed contour volumes. We also had our radiologists and nuclear medicine experts generate a summary of clinical node positivity criteria, and that will be presented. A novel stepwise contouring atlas was produced using both quantitative and qualitative contouring results, along with group consensus, and we now have a total of 10 steps. These were some of the results from the quantitative metrics. Notable here is that the mean Sorensen-Dice similarity coefficients ranged from approximately 0.63 to 0.68. And I think this reflects some degree of disagreement with the existing RTOG atlas, and we felt that this indicated the need for an updated atlas. So this is an example of some of those qualitative metrics that I was referring to. This is the count map analysis. So what you can see here are the colors that are generated represent the number of observers that included a specific region in their contour set. And so what this enables is a nice way to visualize specific areas of discrepancy amongst the contouring observers, and I'll show how we use that specifically. So here are the controversial areas that were identified for the count maps, and we did this for each of the cases, and we identified consistent controversial areas on each of the cases. Those included the presacral region where those mesorectal and presacral nodes end. That included the superior border where the nodal contours actually start superiorly. It included the transition from the external iliac contours into the inguinal contours, and there was quite a bit of discrepancy and controversy in that area. And finally, the posterior border of the obturator lymph nodes had quite a bit of discrepancy, and those areas were focused on for the consensus discussions. These are the new steps that we've generated to create the nodal CTV. We are including starting the contours at the bifurcation of the aorta into the common iliac arteries or the proximal inferior vena cava to the common iliac veins, whichever occurs more superiorly. While this is typically at the level of L4 to L5, we're recommending using the vascular anatomy to form this landmark. As you continue down in the contours are approximately 5 to 7 millimeters around each vessel, and generally we should be including the entire circumference of both the iliac artery and the vein. And there are some circumstances where you may want to be more generous in your contours, and we do describe that and recommend that, particularly anterior to the vessels. The contour margins can go up to 10 millimeters. We also recommend ensuring this coverage posteriorly. So the 5 millimeter to 7 millimeter margin should extend posteriorly as well. So you want to examine for that posterior vascular margin also. These CTV contours should exclude bowel, muscle, bone, and bladder. And we've described some interfaces between the vascular contours. They can be approximately 1.5 to 3 centimeters in width, depending on the patient anatomy. And again, there are times when the contours may be asymmetric, including both the artery and the vein. The contours should end in the presacral mesorectal space at the bottom of S3. And posteriorly, they should follow the pudendal and inferior gluteal arteries, and they should extend approximately 1 centimeter anterior to the vascular structures. You can begin tapering off the internal pudendal artery as you reach the top of the seminal vesicles. And in terms of ending the external iliac contour set as it transitions into the inguinals, we're recommending a transition be examined closely for the point at which these vascular structures cross the most medial point of the acetabulum or enter into the inguinal canal. And you can sometimes see that on the coronal views. This is an example of a coronal view as the vascular structure enters into the inguinal canal. That's where the external iliac contours should terminate. The posterior edge of these contours, as you go inferiorly, should follow the obturator internus muscle, and then anteriorly it can extend approximately 1 centimeter anterior to the anterior edge of the obturator internus muscle. The obturator nodes should end where the seminal vesicles join the prostate, or approximately the mid portion of the contoured postoperative. This is the consensus table describing clinical criteria for node positivity on both CT, MR, as well as PSMA and Axemin PET. And in conclusion here, we have a new NRG consensus atlas, which is presented. We have multiple changes from the past atlas, and we also have included some node positivity criteria. So there's a lot of detail that's included in this new and updated consensus atlas, and we're happy to report that this manuscript has been accepted to the Red Journal. So all these figures, tables, and detailed contour sets will be available for your reference, either via PubMed or this was a very considerable effort by a lot of people, and I just want to acknowledge my co-authors, all of whom committed a tremendous amount of time to this project. I feel very privileged to have worked with them on this project, and I'd like to thank everyone for their attention.